77.
770.
Sorry.
Good afternoon, everyone. I'm Neha. I'm first year DNB student from Jan Swasthya Sahyog, and my topic for today is managing major psychiatric illnesses through teleconsultation in a rural secondary care settings. So, what is the need of psychiatric consultations in rural India currently? If you see the data, the morbidity secondary to the psychiatric illnesses is 70 per 1,000 patients, which is in 100 people, 7 people suffer from the psychiatric illnesses. The stresses in rural areas are far different from the urban areas. Currently, you can see lots of Maharashtra farmers committing suicide. So, the food insecurity, the environment insecurity, with the current stresses around education, lack of education, all these are the stressors which are specific for the rural India. The current suicidal rates which we have calculated for our program area is 43 in 1 lakh population, and otherwise 22 people commit suicide in 1 lakh population in rural India. So it's such a high amount. That is what has propelled us to take a consultation. Especially also the psychiatric illnesses are looked at as a sorcery or a witchcraft in rural India. So treating them is another challenge in terms of psychotherapy. I mean psychopharmacology as well as therapy. Social structure in rural India is again something which is very intricate and also makes the need increase. The current scenario about specialist psychiatric care in rural India is in 2014 the nearest urban area around Ganyari is Bilaspur, which established mental hospital, but the places over there were vacant for more than 6 months, including the chief post for the mental hospital. That is what increases the need for psychiatric consultations in rural India. So how do we assess this problem? How do we really reach out? So we decided to help them out to provide a good diagnosis and appropriate treatment for psychiatric patients by consultant psychiatrist, a specialist care, and also provide a continued specialist care at affordable rate with adequate compliance. So we thought whether telepsychiatry can be an option for us, because getting in an area where mental hospital doesn't work for almost 6 months, getting a psychiatrist, full-term psychiatrist work is again a difficult condition. So a teleconsultation was an option. A teleconsultation as an option has been used even in our Indian films, including Three Idiots, but it has been a good option since 1970s. From which this teleconsultation started in America, wherein a lot of legal guidance was there. But since tsunami incidents in Tamil Nadu, SCARF Association of India, that is Schizophrenia Research Foundation in Tamil Nadu, started a telepsychiatry bus. So that was another teleconsultancy experience in India. So what do we do about how do we use this teleconsultation technology here in India? Here, in our OPD basis, we as residents and our seniors, we screen the patient for the psychiatric symptoms and have them appointed for a teleconsultation clinic, which happens once in a week, mostly Thursdays. And almost 15.63%, that is out of 2040 psychiatric patients, 319 patients were referred for the teleconsultation clinic, which happens on Thursday at our place. A Hindi-speaking psychiatrist from Germany is present at the as a remote consultant at the computer screen, and a resident or a paramedic or a psychiatric nurse is always present to compile, to act as a facilitator for logistic work at the clinic, for giving further appointments and rest all stuff. So this is our psychiatry clinic currently, which happens. The computer screen over there shows the teleconsultant speaking with the patient. The other computer behind it shows the EMR, that is electronic medical record, which is being managed by the teleconsultant himself through team viewer approach. And the psychiatric specialist nurse and consultant is also sitting right in front of patient as a facilitator. So we use electronic medical system at our rural hospital to make the system more easy. We have simple template format. We have just like this. This is one of the template format to assist the mental states of the patient. Like that, we have format for depression, for psychosis, and various other stuffs, so that it becomes very easy for us to maintain the data at the entrance of the patient and also for the follow-up of the patient. And similarly, at the entrance, this kind of format is being provided, and the follow-up format is also different. So the maintenance becomes really easy and recordable. So the outcomes in 3 years, that is from May 2012 to May 2015, is that in 319, actually sorry, I'm sorry, but in 319 patients are seen in 3 years with 1,200 consultations. Nearly 20% of total mental health consultations are done through telepsychiatry, and our pharmacy is very well equipped with psychiatric medicines. Currently, we have escitalopram, venlafaxine, fluoxetine, then olanzapine, risperidone, and mirtazapine also. And for non-compliant patient, we have kept a depot neural preparation to improve the compliance. And that is how it has made a rural pharmacy equipped for the psychiatric conditions. So the common conditions that we see here in our clinic is depression, which is 52%, which accounts most. Then anxiety disorders, 11.7. Schizophrenia, a very severe condition, is 7.5%. Unspecific psychosis and somatoform disorders are there. The less common conditions that we see in our places are mood disorders, personality disorders, schizoaffective disorders, but there are very few, so I did not include it in this slide. So the conclusions for us is teleconsultation is a very feasible model for providing specialist consultation care and reaching diagnosis and getting treatment plan ready. So what did we do is we reduced referral for our clinic, for the mental hospital medical college. Then it was a very good learning experience as a resident for us. We could learn a lot about emergency managing of psychiatric care. We could provide adequate patient satisfaction and also improve the patient compliance. Sensitizing community and forming a support health group that happened actually later, because what we also suggest that just teleconsultancy wouldn't help in getting psychiatric care better. We have biannual direct this consultant psychiatrist direct comes to the our clinic and trains us as such, and that is how we can sensitize community and form support groups. And currently the challenges for our teleconsultation is increasing patient awareness, dealing with the technical issues such as the what do you call, the electricity, the internet, and forming a therapeutic relationship with the patient is always being the first priority for consultant, for the psychiatric consultant. It becomes difficulty as well, and residents' increased training is very necessary. So there is a lot more to achieve. Hopefully we can do that in coming years. Thank you.
Who writes the prescription? Because most of these drugs are scheduled.
So it is the psychiatrist, the one who is at the remote, as a remote consultant, who writes the prescription, and it gets entered in EMR and he gets the drug. And we as a resident are also doctors, so we can prescribe them. And that's not a problem.
You stated that 52% of the people are coming with depression, right?
Yes, sir.
So, how do they accept the fact that they are talking with a person who is thousands of miles away on a TV screen? It lacks the human element.
Yeah.
So, how do they cope with it? Are they opening up as they do within in a one-to-one conversation?
It becomes very difficult for them to open up, especially the psychosis patient. They don't take the fact of seeing through screen stuff, but but eventually whatever that we have experienced, the compliance and the patient comfort with the psychiatric clinic is extremely good. They eventually get used to it, though it's as a first time experience it makes them really feel odd, but then later they get used to it better.
How about the internet connectivity, power supply, all those factors? In many parts of rural India, there are power outages for 12 hours a day.
Yeah.
And if that's the case for power, what's the case of internet can be extrapolated from it. So how is it feasible?
So that's very feasible, sir. If we have willpower, then we can make it really feasible. We have got 2 Mbps internet currently at our clinic, and which is in rural settings. We definitely cannot have a clinic. We cannot have this kind of facility at a very remote area in a jungle area. But then it is at least the nearest contact point for them. So we must build something which is really at least nearer to them. Feasibility is definitely questionable, but we have made it feasible at least for 3 years. So if we take it seriously, we can make it a policy.
So why not train the local GPs over there?
Definitely, that is what is being done, right? We also train Dr. Prashant Gogia, who is psychiatrist at Germany, who comes biannually at our place. He trains us as residents as well as the health workers. So it is not just us. It is sometimes the patient who are referred by health workers come here. We have got a guideline for emergency psychiatric management of psychosis, and it's not us as a resident that we manage it. It is health workers, the village health workers, a woman who has not even read a single word in her life manages that condition. So it has turned out to be a good model. But we also recommend that teleconsultation cannot be everything. We must have training sessions, so learning and training is also important through a direct presence.
There are two schools of thought about using this type of technology. One says that in fact it de-skills doctors because it replaces the doctor on the ground with the technology. The other school of thought is that what you're saying is that in fact it improves his skills. Is there any way that you can measure if it's had an impact on your clinical skills and your prescribing and your referral rates as a result of this technology?
Yeah, sir. Actually, we've mentioned also that almost 15.63% have been referred to telepsychiatry by us. And Prashant sir, the psychiatrist has trained us. So there's a clinical impact on clinical skill. I cannot really comment on it, or we have not exactly measured it. But that's not the ultimate problem which we faced. We think that addressing the immediate need is more necessary than getting a proper. I hope I can. I'm not sure. I'm not really good at it.
What I'm saying is, do you think that you could measure your referral rates after a period of time?
No, we have not measured our referral rates. Whatever that we do is we refer to our telepsychiatric consultant. And we have emergency consultations as well, sir. So that does happen.